So I'm Julia, and I'm very excited to be bringing you the much anticipated new ART abridged guidelines. We know that this is a huge milestone for South Africa to be rolling out dolutegravir. We're doing phenomenally. And these guidelines took a lot of thought and consideration. That's why they took a bit longer than we all expected, and why the consolidated guidelines are still in process and should be released hopefully by the end of August. But for now, we have these abridged guidelines, and how they were made was by a bunch of our experts in South Africa from all the different academic institutions, our pharmacologists, infectious diseases consultants, pediatric infectious diseases consultants, people from WHO, from NDOH, from partners, all the who's who of HIV in South Africa and internationally. The names of Francois Venter, Michelle Moorhouse, James Nuttall, Karen Cohen, Gary Martins, Leon Levine, Brian Chirombo, Leslie Bamford, Dr. Panini, the list goes on and on, Mo Archery, you know all those names. And they've spent a lot of time discussing, debating a lot of points. There were lots of things to consider because we wanted to come up with guidelines that were clinically appropriate as well as programmatically appropriate. And you know that juggling those two is always quite a feat. So this is what they've come up with. And as you'll notice, my name was not in there. I did not write these guidelines, so I don't deserve any of the credit today. I'm merely here to help with the training of these guidelines. And in that vein, if you decide you don't agree with something that's in the guidelines, please don't shoot the messenger. So what we're going to cover today is just the goals of ART and our progress to date, the drug-related changes, namely dolutegravir, how to reinitiate treatment interrupters, how to monitor on ART, and how to switch regimens, and then TB preventative therapy. So how are we doing so far? The 90-90-90 goals. From UNAIDS December 2018 data, we were at 90% of our South Africans with HIV know their status, 68% of them are on their ARVs, and only 78% of them are virally suppressed, which gives us an absolute of only 47% of all our people living with HIV who are actually virally suppressed. So we can see a lot of work still needs to be done on that, and these guidelines are hoping to address that, but we know that there's a lot of programmatic challenges that have to be addressed at the same time. So what are the goals of ART? We all know it is to achieve and maintain viral suppression, because that will decrease our opportunistic infections, it will prevent treatment resistance, it will decrease morbidity and mortality, and it will improve quality of life. And we have to do that at the same time as minimizing the side effects and toxicities from treatment. And that's where our new dolutegravir really is a step forward, especially from the days of D4T and AZT and those poorly tolerated drugs. We really are moving ahead now. So how do ARVs work? I think everyone in this room knows how they work, but here's a nice diagram to just summarize how the different classes of ARVs have their effect at the different stages of the HIV life cycle. And today, the most important one is the integrase inhibitor, because that is our new class of drugs that we're bringing with dolutegravir. So how it works is basically once that viral DNA has been created, the enzyme integrase takes that viral DNA into the nucleus, and it takes the host cell DNA and basically chops it and inserts the HIV virus's DNA. So the cell doesn't know that there's HIV DNA in there. And then the cell will replicate HIV for HIV. That's how sneaky HIV is. So what integrase inhibitors do is they block that enzyme integrase. So that viral DNA might be made, but it can't be integrated into the host cell DNA. So therefore, the HIV virus can't replicate. And that's how we achieve viral suppression. So some examples of integrase inhibitors. Here's our list. Dolutegravir is obviously the exciting one that we're getting now. Raltegravir we had for a while, we used in third line. It's not as robust a drug as dolutegravir, and it can develop resistance. So we actually want to stay away from that. And then cabotegravir is one that is quite exciting to look out for in the future because that is given as an intramuscular injection. In the bum actually. And so in the future, cabotegravir combined with rilpivirine might be where we're going, and people can receive one injection every 2 months, which will be great. So keep your eyes open for that. But for the moment, dolutegravir is our very exciting new addition. So here's another nice diagram that you can use to explain to all the clinicians you're going to be training on how that viral DNA becomes integrated into the host cell DNA. And when you have integrase inhibitor, it blocks this integrase enzyme, so that doesn't happen. So a quick overview of dolutegravir. So as exciting as it is, and as you can see, it's phenomenal, there are quite a few intricacies, which are going to be all of our jobs to educate South Africa about, because we want this to be done properly. So why are we so excited about dolutegravir? Well, firstly, we've got a great fixed-dose combination, TLD, you would have heard of. It's the combination of tenofovir, lamivudine, dolutegravir, TLD. Dolutegravir causes the fastest rate of viral suppression. In 8 weeks, it can suppress the HIV virus. It is a very potent drug. It is well tolerated generally. In the studies that compared dolutegravir to efavirenz, patients did better on efavirenz mainly because better on dolutegravir mainly because they tolerated it better, and there were less people defaulting because of side effects. It has a high genetic barrier to resistance, and I'll explain that terminology in a few seconds. There's no drug interactions with contraceptives, which is very useful. And very important, and one of the big changes that we're going to see going forward. So the doses and formulations. Dolutegravir is given at a dose of 50 milligrams daily, usually, and we get 2 different formulations that we'll have in South Africa. The one is the single tablet of dolutegravir, 50 milligrams. The other formulation will be the TLD combination tablet. Tenofovir, lamivudine, dolutegravir. The big thing to note here, that we will discuss again in detail, is when someone is on TB treatment with dolutegravir, the dose needs to be doubled. As we did with Illuvia, but now it's just slightly different. So what we'll do is if someone is on their TLD tablet, say they are taking it at night, we will add a dolutegravir 50 milligram tablet in the morning, so 12 hours before. If they are taking their TLD in the morning, they will then take an additional dolutegravir 50 milligrams at night. Everyone got that? Okay. And this is such vital information because South Africa already has one of the first people in the world to develop dolutegravir resistance. And it was a private patient who was started on TLD as her first treatment ever, never had anything else, but she developed TB and was told, you must take dolutegravir 50 milligrams in the morning as well. She decided she didn't like taking that extra dose. So she didn't, and she's developed dolutegravir resistance. Okay, so this is something that we have to get out to every clinician out there. If they are on TB treatment and dolutegravir, we need to make these changes. Okay. So now for rollout, we've got 8 different companies making TLD, which is great news because that should give us a good supply and it should cut out a lot of our supply chain issues and our drug stockout issues. So that's why one of the main aims of these guidelines is to try and get as many people as possible onto TLD. But because each of these companies gives their product a different name, this might be confusing for patients, so we always need to remember to tell them Each company makes their own drug and gives it a different name. So don't worry if this month you get given Acryptega and the next month you get given Radin. What they need to know, and the names are a mouthful, what they need to know is I think we should tell every patient, write down the names for them: tenofovir, lamivudine, dolutegravir. These are the 3 medicines inside your 1 tablet. And whatever box of pills you get, look for those 3 names. If those 3 names are right, you've got the right medicine. We have to empower our patients. Okay. Then, the next big concern about dolutegravir that I think you all heard about, April last year when we were getting very excited to roll out dolutegravir, Botswana, who had beaten us all to it and had rolled out dolutegravir, they suddenly did an analysis of their women who had had babies while they were on dolutegravir, and they found a slight problem. That problem was an increased number of neural tube defects in babies who were born when the mother was on dolutegravir during conception. So they found 4 neural tube defects out of 596 women. So that gives us an incidence of about 0.67, compared to their normal incidence in Botswana of ladies on other ARVs at conception who had an incidence of 0.1%. So it's almost a 7 times increased risk. So instead of 1 in 1,000 babies getting a neural tube defect, now they had 7 in 1,000. Okay. But we don't know yet if this was just coincidence or if this was genuinely due to dolutegravir. So the whole world kind of halted their rollout plans, and we've been trying to watch and wait and explore the other evidence, and in no other studies we've found the same problem. So it's looking positive, but we have to wait until we've got proper evidence to say that dolutegravir doesn't cause neural tube defects. We don't know yet. And the problem is that neural tube defects are not just a minor problem. We'll need to explain this to all our nurses and patients in the country, that neural tube defects, what they are is when the baby is a tiny little bunch of cells. In those first 4 weeks of development, it develops the neural tube, which is basically everything from the brain down the spinal cord. And that neural tube forms and closes. If that does not occur properly, there can be a hole in that neural tube, and you can have an open spine with your nerves coming out, spina bifida. You can have anencephaly, which means your brain doesn't form. Your head and your brain don't form. These can result in death, paralysis. They are severe consequences. So that's why it's not been something we wanted to play around with. The good news, as I say, is we haven't seen any neural tube defects in any of the other studies, and we haven't seen any other adverse pregnancy outcomes if dolutegravir was given after the time that the neural tube has developed or during pregnancy. We have not yet seen any problems. Doesn't mean there definitely won't be any, but at the moment we don't think there are. So what do we need to do? We need to be cautious in giving dolutegravir to women who want to conceive, women who are not on reliable contraception, and women who are pregnant in their first trimester. And I know I said the neural tube closes in the first 4 weeks. We've extended this to cover the first trimester because often patients aren't quite sure of their dates, and we're just trying to err on the side of caution. That's why that was put in. So it is recommended that, you'll see this new abbreviation that is all over the guidelines, women of childbearing potential. It is recommended that women of childbearing potential that do not currently wish to become pregnant use contraception if using dolutegravir to prevent them unexpectedly falling pregnant and having a baby with a neural tube defect, or possibly. So then I think you all know that we didn't know what to do with this information. We thought, okay, then should we just give to males, not to females? Because how do you check that everyone's on contraception? This is going to be very difficult programmatically. But the civil society and women's group activists, they spoke, they had their voice heard. And they said it is unfair to give just men this wonderful drug and not us. Women should be given the autonomy to make their own choices and their own decisions, especially because this is a potential risk that we don't actually know if it's true or not. So what we are going to do for all our women is basically a 3-step process that is understanding their fertility intentions. Do they want to have a baby? Are they pregnant now? When do they want to have children? Secondly, giving them the risks and benefits of dolutegravir versus efavirenz, so they can understand the pros and cons. And then thirdly, providing them with contraceptive options. And I know that this is something that hasn't been done very well in the past, integrating our family planning services and our ART our ART services. This is the time for that to change. Okay, from now on, we're going to push patients on ART and family planning as an integrated service, and that's actually a real positive for our country. Okay. So what are other adverse events reported with dolutegravir? Well, it can cause the common side effects that most drugs can cause, a bit of nausea, a bit of diarrhea, a bit of headache, but they're generally mild and self-limiting. They aren't as severe as Illuvia side effects. Another one that we have seen with dolutegravir is insomnia. And that's why some patients have said if they take their TLD at night, they have insomnia or nightmares, they don't sleep well, then for those patients, try taking it in the morning. And a lot of them say that was much better. But we don't want to force everyone to take it in the morning because a lot of people will already be in their routine from taking their efavirenz ARVs at night. And if they're adherent on that, we don't want to go and mess up everything. So we give people the option. They can take their TLD as they were or as they want to. If they experience insomnia, they can change to the morning. Then weight gain is another thing that we have seen in virtually all the dolutegravir trials. Weight gain from 1, 2, 3, 4 kgs. It was especially when it was combined with TAF, which ours isn't, but this is still definitely something that we need to warn patients about and ask them if weight is an issue. This is a potential side effect. And I'll go into that a little bit more just now. This is just one of the studies showing the frequency of adverse events in Brazil of people on dolutegravir. And you can see it's these normal gastrointestinal, neurological, sleep disorders, skin disorders, mental, systemic symptoms, and musculoskeletal. But the incidence was very low. And as we said, mostly mild and self-limiting. In all the comparisons with efavirenz, there were much less side effects with dolutegravir. Now, another point, okay, is that dolutegravir can cause an increased level of creatinine. But it is benign, okay? Benign means this is not a problem. It is not pathological. It does not cause damage. So basically, you know, in the kidneys, you have the glomerulus that filters the blood, and creatinine is filtered through the blood into the urine, which is then excreted. So we use creatinine as a measure of your glomerular filtration to see is there damage in that glomerulus, and the creatinine isn't being filtered out well, therefore your blood creatinine levels will be higher. Okay, so that's why we've always monitored creatinine with tenofovir, to check if there was kidney damage. So it's completely different to dolutegravir, because what dolutegravir does is not in the glomerulus, in the proximal tubules, creatinine is also secreted via an organic cation transporter protein, okay? And what what the integrase inhibitor dolutegravir does is blocks that organic cation transporter protein. So the creatinine is not secreted from the blood into the tubules, into the urine to be excreted. Therefore, the levels in the blood will be higher. But as soon as you stop taking dolutegravir, that transporter works again perfectly. Okay, so it just blocks it while it's there. When it's not there, it works perfectly. It is not causing any damage. I want to get that completely clear. Dolutegravir does not damage the kidneys. Okay, but it can cause an increase in the creatinine. So now, when we've got a patient on TLD, tenofovir, which can cause kidney problems, and dolutegravir, which doesn't but raises the creatinine, you'll ask the question, well, how do we know if the raise in creatinine is a problem or not? And what we've said is that dolutegravir normally usually only increases the creatinine by about 15%. So it's usually 10 to 20, but 15% is the cutoff, okay? And it normally happens within the first month. So it happens soon. And it goes up, and then it stays up. Until you stop dolutegravir, it comes down again. So if you see a rise in creatinine that is less than 15%, and it stays the same, it doesn't continue rising, then we can say it's dolutegravir, it's fine, no problem. But if your creatinine continues to rise, then we're going to work them up as we always did for tenofovir problems or other renal problems. Is that clear? Okay, so you all know dolutegravir does not damage the kidneys. The next thing, as I said, there's many intricacies, is drug interactions with dolutegravir. So generally, dolutegravir is quite good in terms of drug interactions. As I said, there's no drug interactions with contraceptives, which is very important for us because we want all our patients to be on contraceptives. And because with efavirenz, we used to have a lot of problems with contraception. But there are a few other drug interactions that we need to know about. So the first one is rifampicin that I've already discussed. It decreases the level of dolutegravir, so much so that it will cause resistance to dolutegravir if we don't give that additional dolutegravir dose. Okay, and I've explained that. If you're taking TLD in the night, you'll take 50 milligrams dolutegravir in the morning, if the other way around, vice versa. The next drug interaction is anticonvulsants. And now we know with efavirenz there were drug interactions also, but valproate used to be our safe one. Now dolutegravir has an interaction with valproate. So our patients on sodium valproate who want to go onto dolutegravir will have to change their anticonvulsants if they want to go onto dolutegravir. So the safest anticonvulsants is lamotrigine. That'll probably be our go-to. And then there's these two other anticonvulsants, which I think are only able to be prescribed by neurologists at the moment. If you don't have any of these three to change the patient onto, you can give them carbamazepine, but then the dolutegravir needs to be double dosed again. So that morning dose and evening dose, the same as we do with rifampicin. Okay? But otherwise, patients could just stay on TEE. We want to get as many as possible onto TLD, but we don't want to cause chaos or take stable people and mess up their treatment. Okay? Then metformin is the next one. That's quite a commonly used drug and does have drug interactions with dolutegravir. But in this case, it doesn't affect the dolutegravir concentration. The two together affects the metformin concentration. So what will happen is the metformin concentration will rise. So we don't want to give people very high doses of metformin with dolutegravir because their metformin concentration will rise and they might get hypoglycemic. Although in the studies it did show a rise in metformin concentration, but there weren't actually an increase in hypoglycemic events or lower glucose levels. So, but it's something that we do need to monitor, and the recommendation is that the maximum metformin dose should be 500 milligrams 12-hourly when given with dolutegravir. We don't want to go any higher than that. And I would suggest telling the patients to just watch out for hypoglycemic symptoms. And this is one of the reasons that we'll discuss a little bit later, the rollout of dolutegravir in chronic patients, especially with diabetes, other comorbidities, needs to be a slow and careful process. So our CCMDD patients who have comorbidities, we have to go slowly, and we're going to have a whole staged process to our CCMDD patients that we have not fully finalized at this moment. But we don't want people to just go out there and change everyone, because it can cause chaos. Then our next drug interaction, which can cause problems, is with our polyvalent cations. So this is things like iron supplements, calcium, magnesium, and aluminium, which are all in our antacids. And I'll show you what they do. So this gets a little bit tricky. So put your brains on, but we want to try and make it simple. So dolutegravir, when given with calcium or iron without food, causes a decreased dolutegravir level. Okay? But dolutegravir given with calcium or iron with food has no effect on dolutegravir level. Okay? But calcium and iron cannot be given together. They have to be given at least 4 hours apart. Okay? And there's another point. Dolutegravir with the antacids like magnesium and aluminium containing antacids, regardless of whether it's with food or without food, causes a decreased dolutegravir level. So we want to take them at least a minimum of 2 hours before or 6 hours after taking dolutegravir. Okay, I'm going to repeat this because it is quite complicated, but we need to get this message out correctly. So dolutegravir, when given with calcium or iron without food, causes decreased dolutegravir levels. But when they are given with food, it does not affect the dolutegravir levels. But they cannot be given together. And then the magnesium and aluminium containing antacids will always cause a decrease in dolutegravir level, so you want to give it either 2 hours before or 6 hours after dolutegravir. So we've tried to make it simple for everyone, and basically we've given 2 options that make it a lot simpler to get your mind around. Option 1 is, and these are particularly for pregnant women, because what are they on? Calcium, iron. Often they're going to have reflux as well and need some antacids. So our option 1 is to take your dolutegravir and your calcium supplement with food in the morning. Then at lunchtime, you can take your iron supplement with your lunch. Then in the evening, you can take your other calcium tablet with your food in the evening. So it's quite simple. The other option is if you are taking your TLD at nighttime, then you'll take your dolutegravir and calcium in the evening, your iron supplement at lunch, and your calcium other tablet in the morning with breakfast. So this makes it a whole lot simpler, right? Okay. So it's the 2 options of either taking dolutegravir in the morning or the night, and then you space out your calcium and iron. Then other drug interactions, there's actually there's no drug interactions with hormonal contraceptives, with antimalarials, with rifabutin, with most antiarrhythmics, beta blockers, antidepressants. So it is quite good on the drug interaction front, except for those ones that I've told you about. But remember, there is this online HIV drug interaction checker that I think every clinician should know about and use. None of us can remember every drug interaction. And the easiest thing to do is just plug in those drugs, their whole list of their chronic medications, and see is there a drug interaction or not. And if there is, you can call an expert for help.